Hi everyone, today we're going to be talking about the two main inflammatory bowel diseases, Crohn's vs ulcerative colitis. Inflammatory bowel diseases are caused by chronic idiopathic inflammation. It has a bimodal age distribution, with most being diagnosed around the ages of 20 to 30, and another smaller peak at age 40. Unfortunately, the prevalence of IBD is increasing worldwide due to a multitude of risk factors, and it also has a male predominance, 1.5 to 1 in ulcerative colitis and 2.3 to 1 in Crohn's disease. One of the very important ways in distinguishing Crohn's from ulcerative colitis is knowing the location of involvement. Crohn's can involve any portion of the GI tract, however, it likes to involve the colon and the ileum. It can also involve the mouth, leading to mouth ulcers. Crohn's is characterized by skip lesions, meaning that the lesions are not continuous. It's also rectal sparing. Ulcerative colitis always involves the rectum and colon with continuous lesions. Now let's talk about each specifically, starting with Crohn's disease. So I put a picture on the left of a person with abdominal pain, and as you can see, he's putting his hand over his right lower quadrant. This is to help you remember that Crohn's disease presents with abdominal pain that's mostly in the right lower quadrant due to the involvement of the terminal ileum. The abdominal pain is also associated with mostly watery non-bloody diarrhea. However, in cases of extensive colon involvement, called Crohn's colitis, it can present with bloody diarrhea. And I mentioned in the previous slide, it can also involve aphthous oral ulcers. Next, I'll talk about the complications of Crohn's that pertain to the gastrointestinal tract. So let's start with fistulas. Perianal fistulas are the most common type. They are associated with anal fissures and abscesses, and they present as anal pain. A patient with Crohn's can also present with signs and symptoms of urinary tract infection and pneumaturia, which is basically gas bubbles in urine. This should indicate to you the presence of an enterovesical fistula. Other fistulas include bowel to skin fistulas that lead to skin infections, bowel to vaginal fistulas, and bowel to bowel fistulas. A patient with long-standing or untreated Crohn's can have extensive involvement of the small intestine. This leads to malabsorption and in turn weight loss. A patient with Crohn's can also present with signs and symptoms of intestinal obstruction. This is because of stricture formation, which is a characteristic of Crohn's disease. Crohn's can also cause abscess formation due to neutrophil infiltration at the crypts of Leberkuhn. I talked in the last slide about perianal fistulas and abscesses. Colorectal cancer occurs in the case of Crohn's colitis. When you take a blood sample from a patient with Crohn's disease, you can find an increase in the number of white blood cells called leukocytosis, iron deficiency, and rise of inflammatory markers like ESR. Vitamin B12 deficiency can also occur due to terminal ileum involvement. So Crohn's can lead to anemia due to mixed causes. The first is iron deficiency, the second is vitamin B12 deficiency, and the third is anemia of chronic disease, whereby an inflammatory marker, hepcidin, restricts the use of iron in synthesizing new red blood cells. On radiography, you can see strictures and bowel wall thickening. The picture on the left is a fluoroscopy, where you ask the patient to swallow a contrast material, then you wait 3 to 4 minutes and then take an abdominal X-ray. You can see the string sign, which is a very common sign in Crohn's disease. Another sign you see on the CT scan is creeping fat, which is when the inflammation of the bowel involves the fat around the bowel wall. The following pictures are pelvic MRIs. These two show enterovesical fistulas right here, and the one on the right is showing a stricture. On an endoscopy, you can see focal ulcerations next to normal mucosa. This is called cobblestoning, which is a characteristic of Crohn's disease. I've put a picture here to show you how cobblestone looks like. You can see here you have the focal ulcerations right here, and here is the normal mucosa. You can compare the two pictures to help you understand. When you take a biopsy, you can see transmural inflammation, non-caseating granuloma as you can see in the picture, with lymphoid aggregates. Now I'll talk about ulcerative colitis. Ulcerative colitis presents with bloody diarrhea that's usually nocturnal, associated with abdominal pain and tenesmus, which is a frequent urge of defecation without being able to, likely because of the inflammation involving the rectum, also fever and chronic fatigue. The inflammation of the bowel in ulcerative colitis can lead to a couple of complications. Fecal incontinence is loss of control over defecation. Fulminant colitis is when the inflammation involves the entirety of the colon. The inflammation can also cause dilation of the colon, as you can see in the X-ray on the right. It's called toxic megacolon, along with perforation. Malnutrition and weight loss occur in case of long-standing or untreated ulcerative colitis, along with colorectal cancer due to extensive involvement of the colon. Blood analysis yields leukocytosis, anemia due to mixed causes, and reactive thrombocytosis. Inflammatory markers are elevated like ESR. Late pipe appearance on imaging due to loss of hostra. Colonoscopy and flexible sigmoidoscopy will show continuous and circumferential erythematous and friable mucosa, superficial and deep ulcers, and pseudopolyps. The X-ray on the left shows lead pipe appearance, and X-ray on the right shows how a colon full of pseudopolyps appears on X-ray. This picture of an endoscope shows how pseudopolyps look like. The inflammation in ulcerative colitis is mucosal and submucosal inflammation only. It can also form crypt abscesses, but there are no granulomas. A variety of systems in the body are also affected by inflammatory bowel diseases. In the musculoskeletal, IBD results in peripheral arthritis and spondylitis. In the X-ray on the left, you can see the bony spurs, a sign of spondylitis, and on the MRI, you can see the signs of inflammation of vertebra at the orange arrows. In the eyes, it manifests as episcleritis, scleritis, as you can see on the right picture, and uveitis in the picture on the left. You can see the ciliary flush, hypopyon, and the red sclera. These are signs of uveitis. On the skin, it manifests as erythema nodosum, as you can see on this picture, and bioderma gangrenosum, although less commonly on the right. Extraintestinal manifestations of Crohn's disease include calcium oxalate kidney stones and gallstones. They are associated with anti-Saccharomyces cerevisiae antibodies, while specific manifestations to ulcerative colitis include primary sclerosing cholangitis, which is associated with myeloperoxidase ANCA, otherwise known as p-ANCA. The main treatment for IBDs are immunosuppressants like azathioprine, anti-TNF therapies like infliximab and adalimumab, anti-alpha-4 integrins like natalizumab and vedolizumab. These are known as maintenance therapies that reduce the inflammation of the bowel wall. These help to improve symptoms and course of the inflammation in the long run. However, they need a long time to act, so we temporarily give corticosteroids to alleviate the symptoms and to help with compliance. Medications that are specific to ulcerative colitis include 5-aminosalicylate acid containing medications such as sulfasalazine and mesalamine. Fecal calprotectin is used to monitor disease activity and distinguish from other non-inflammatory diseases like irritable bowel syndrome, which may have similar symptoms. It is very important to start screening for colorectal cancer, especially in patients with ulcerative colitis. They must start screening 8 to 10 years after diagnosis. We do a colonoscopy every 1 to 3 years. It is very important to make the distinction between colitis-associated colorectal cancer and sporadic colorectal cancer. Colitis-associated colorectal cancer starts at a younger age, 40 to 55, while sporadic is in an older age, above 60. In colitis-associated, it's proximal more than distal. In sporadic, it's distal more than proximal. In colitis associated, it's a multifocal tumor, while in sporadic, it's only a single tumor. In colitis associated, it's poorly differentiated, while in sporadic, it's well differentiated. Finally, the mutations, colitis associated has early p53 mutation and late APC mutation, while sporadic has a late p53 mutation and early APC mutation. So most of the differences are just the exact opposite, which makes it easier to remember. Thank you for watching.